really aligns with the work of ChildKind. And so this is why I've really chosen to talk about this. It's sort of the foundation on which the comfortability is built, but we're going to pull back and really take a look at sort of what's needed to do this kind of work and why it's so important in pushing the ball forward in the field. Just a few disclosures. So I'm going to be talking about the Comfortability Program. This program is licensed to our partner sites through Boston Children's Hospital. Some of those licensing fees come back to fund the program and the research lab, of which I am a member. There's no commercial involvement. And then also that I do receive royalties from the book I published on chronic pain management. Okay, so we're going to talk really specifically about three things today. One, the gaps in psychological care for the treatment of chronic pain. Where are we getting stuck? Because we've got a lot of actually amazing, incredible work happening in the field, but there's definitely places where we're really, where we are stuck. And then I'm going to just talk a little bit about what's an implementation science framework and how can this thinking really help to unstick us. And even though I'm going to be really talking about what's happening in psychology, like I said, this has much broader implications for how we think about the work that we're doing, creating innovations and interventions wherever. And then I'll talk at the end about the Comfortability Program and how it's really used these principles to create and sustain the work that we're doing in delivering evidence-based psychological care. So those are the things. I'm not going to talk about why psychology is important in pain treatment, but and every talk starts that way, like it's really common and it's really important. Let's just work together from these basic assumptions. Pain's always biological, psychological, and social. Psychological interventions, an essential part of multidisciplinary treatment and does not imply causation. Kids need intervention because the vulnerability and resilience factors directly influence a child's recovery. We've got decades of research to show that that's true, and also that many, not all, but many of these are modifiable with very brief evidence-based interventions. And then lastly, that caregivers also need intervention in pediatrics. Their language, their behavior directly contributes to a child's function and recovery, and kids and parents need to partner together. So we're just going to all agree that these assumptions, we hold these assumptions to be true, and that they underlie the work that I'm going to be talking about. Okay, so what's going on with the gaps in care right now? I will say that in the world of psychology in pediatric pain, right, we're like in pediatrics, clinical psychology, and then in pediatric psychology, and then in pediatric pain psychology. So we're really like in a niche here. But it's an incredibly exciting time to be a psychologist in this field. There is so much opportunity for innovation. Pediatric pain is still in its nascent stage of research and discovery. There is never going to be one intervention or even an intervention package that works for everybody in every setting. So there's a lot of space for generating new ideas and new solutions. And that should be really energizing. I hope that's energizing to people in the field. The end game is that likely there's going to be multiple touch points along a clinical care pathway where people are going to access intervention. And so maybe there's more brief interventions, maybe there's more disease targeted interventions. So there's lots of ways to think about how we approach this. Some might be virtual, some might be in person, some might be app-based, lots of different opportunities here. And, the thing that we all come up against is that we've got tons of evidence now that psychological strategies are helpful and also vastly underutilized still in the day-to-day of most pediatric patients with pain. They're not getting access. And it really boils down to these three things: limited resources at the level of the consumer and the provider. And what I mean by that for the provider is just there aren't enough pediatric pain psychologists to go around. They're not embedded in every institution. When we think about rural healthcare, there's hardly any access at all. there's still mental health stigma. So still we run up against the bias around using psychology to treat what so many people still believe to be a biomedical problem. And then tied into that, the lack of knowledge about efficacy, the consumer and the provider level. So lots of people just not understanding the how and why of psychology, being integrated into this, that sort of idea of buy-in and how important that is. So I think, we know that health, pediatric health in general, is not just the absence of the disease or the infirmity, but includes the psychological wellness of a person. How that manifests right now in our current healthcare system, it's not great. It's not great. We're getting better, but still, anybody that's practicing in this field or doing research in this field, I think is really well aware of these gaps. So as I talk about, as I move through talking about this, if you're not a psychologist, I just encourage you to think a little bit about where are the gaps in the field that you're practicing in as it relates to pain. They're in nursing, they're in, physical therapy, medicine, all of the above. So just, maybe think about the framework from your own provider experience and context. Okay, so let me just sort of break down, and this is maybe the part where this is the difficult part. Everybody's like, well, like these are the things that we're up against. So there are producer level barriers. So this is the fact that this research to practice gap exists because so much of new research coming out is done in highly controlled study conditions. These are really important to understand what works, what are the building blocks of what works and for whom, the idea of the tailored intervention. And also, this sort of linear production doesn't often doesn't often take into account the generalizability of what's going on. We really sacrifice the internal validity for the external validity. And there's just like a massive information overload. It feels like I often say it feels like you're trying to drink from a fire hose. Like there's so much coming at us at the producer level right now. It's really hard to synthesize and integrate and understand what's going on. So those are the research producers. And then at the provider level barrier, we're all really burdened in our jobs. Like the ask for anybody working in healthcare right now is massive, and everybody is really feeling that pressure. There's no time for program development a lot of the time, or the people that are the providers don't necessarily have that skill set to create and innovate those things. And of course, we all are working in silos, even within our field. So like even psychologists, working in pain might be siloed from psychologists working in neurology or transplant. And then there's institutional level barriers as well. So our healthcare systems, if anyone's working in academic medicine, they are really complicated. They're often feels like you're dinosaurs trying to like move and innovate and create new infrastructure. It's hard. And there's outmoded procedures for implementing change. So it just takes moving an institution is heavy lifting. And then finally, the patient level barriers. So health inequity with limited access to services. Again, like I mentioned, that mental health stigma and the lack of knowledge about treatment efficacy. So these are really the things that get in the way of getting our research fluidly into practice, because that's the dream, right? That's what we all want to be doing. And so what it boils down to is this idea of what's called knowledge mobilization. And this is really the synergy between researchers, practitioners, systems, patients, and families. This is like the kumbaya, right? Like we need to all be working together. And in theory, it sounds lovely. In practice, it's tough. But this idea of knowledge mobilization is really, I think, what's at the forefront of where we're headed in this field. Canada, this idea of knowledge mobilization, I should say, it's just booming in Canada. We're still really behind with this idea in the US, and we need to do some catch up there. But like in Canada, knowledge mobilization, you can get your master's degree just in that as a field that does not exist anywhere in the States right now. But just by definition, so we're all on the same page here, knowledge mobilization. It's an umbrella term, encompasses a wide range of activities that relate to the production and dissemination, of research results. We're talking the knowledge synthesis, dissemination, the transfer and exchange, co-creation and co-production. That means working with patients and families. And within that umbrella, you've got two arms. You've got knowledge translation and also knowledge dissemination. So how do we take what we know and translate it into really innovative, engaging kinds of interventions? And then how do we get that out and sustain it as well? And I think that these areas, I just want to put a plug in to say that this part of it, that sort of action part of this cycle, is really tied in to what's in the forefront of everyone's mind, I think, or I hope, which is this idea of health equity in terms of how do we eliminate health disparities for marginalized groups and improve access to health. And that is really a big part of this knowledge translation and dissemination. Okay, the key considerations for knowledge mobilization, when you pull back and you're thinking big picture here, we're thinking about how can you create something and get it out there and maintain fidelity so that you know that you can expect similar outcomes if you design something under a controlled circumstance, or if you're working with evidence-based content. How do you make sure that when you disseminate, it's got high fidelity, that it's doing what it's supposed to do when it's shared? How can you be flexible in the dissemination? There's never going to be, even within our sort of academic medical centers, and I've worked with many of them now, they are so different. The infrastructure, the politics, whatever it is, they're hard to work with. And so how do you think about creating something that can be flexibly adopted? And tied into that, at the core, it's great to get it out there, but how do you sustain it? That's a big piece of this as well. So let me just talk for a minute about what's an implementation science framework, because we know we've got these gaps. We know we need intervention. We know kids and parents need help. We know there's a strong evidence base. How do we think about shaping that, delivering that? And that's where implementation science really comes into play. So I want to introduce you to a couple different frameworks for thinking about this. And just like there's not one size fits all solution, I don't think actually, I think all of these frameworks have something to offer, and they certainly get us rethinking a little bit about how it is we're designing the research that informs the work that we do. So the first one is the RE-AIM framework. And RE-AIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. And this was first designed or put out there in the literature in the late 1990s. And really with this recognition that there was too much focus on the internal validity and not enough on the external validity. So it's really a research framework to think about focusing on the steps and the design and the dissemination and the implementation process that can either make things fly or make things, fail. And how does that change or shape the actual intervention itself? And so really looking at all of these pieces of the puzzle from the ground up. And I think that that's just a really important framework to keep in mind. And the goal then is, at the end of the day, is to develop something that you've got pretty high confidence is going to be generalizable and successful. Building on that, in the early 2000s, the PRISM model came out, and PRISM stands for Practical, Robust Implementation and Sustainability Model. And the idea for this model is that you're really looking at the setting level maintenance characteristics. So we're thinking about, if you're designing something, what are the job requirements that are going to be required to deliver this? Like, who's the boots on the ground for doing this work? What's your mechanism for feedback? How do you continuously learn from how it's going? Because of course, jobs change over time, systems change over time. So what's your mechanism for feedback? And what's the institutionalization of the intervention and the related activities? Like, how is this being held within the system? And whether it's an academic medical center or a community-based intervention or something that's based in a primary care setting, like there's so many different ways to think about where a touch point in a clinical care pathway is being held. But right from the ground up, we need to be thinking about that. And that requires sort of these macro level factors like policies, guidelines, incentives, and also the sort of micro level factors at the organization level. Something just as basic as like, how do people, train for this? Where does the money come to do anything, related to this? So thinking about all of those. Another thing that really comes up when we're thinking from this implementation science framework is the fit. So, we'll talk in a few minutes about the comfortability program. But this idea of fit is a really important one because the comfortability program works at a lot of places, but not all the places. And we've definitely had sites approach us and say, we'd really like to train and launch your intervention. And that then becomes a two-way discussion. It's not just that they want it, it's that what is the fit? We're not going to share and train and support a site in implementing if it doesn't seem like the site, the institution, the providers, whatever it might be, has the right fit for being able to deliver with high fidelity and sustain the intervention as well. So you're looking at the whole system here, which is important and different. Another framework is the knowledge to action cycle. And I'm going to go into this one in just a little bit more detail. This one is really helpful for sort of guiding the generation of new material and the testing and the dissemination phase. A little bit less of a research focus as the REAIM and the PRISM, but this is really the framework that we've used with comfortability to sort of guide the work that we're doing as well. And so I'm going to explore that with you in just a minute. But what I want to just highlight here is that, okay, these came out 20 plus years ago. And so recently, well, not recently now, in 2015, 15 years after these came out, there was a systematic review to look at, okay, how are we doing? Which is a really good thing to do. And still what they found was most of the interventions were really just focused on effectiveness, that internal validity, what's working within our controlled environment, and very few were really thinking about or prioritizing reach or organizational maintenance, less than 5%. So this gives you a sense of like, well, with that research to practice gap, like we get it. We know why this is happening because we really have to think big picture here. So I want to walk you through a few of these steps because some of these things I think we're, as a field, really, really good at, and some of them are way harder. So this first part is the knowledge creation cycle. I actually think, I just came from ISP and was way impressed with incredible, innovative ideas coming from there. And this idea, think about this, it's sort of shaped like a funnel with intent. If you think about that sort of fire hose analogy, right? Like there's so much coming at us. How do we synthesize it? How do we take what we understand in the field and produce some tools that really hang on our best evidence base. And that's going to shift over time. We have to be nimble, of course. There's nothing static about this. But at any time, we have to be able to sort of say, what's out there? What are the outliers? But what really can we ground ourselves in with this work? And so this knowledge inquiry, this really has to do with synthesizing that piece of it and tailoring it for our pediatric pain-specific populations. The next part of it, the action cycle, this is where it gets tricky. This is, in contrast to the knowledge creation cycle, this one is messy. It's not linear. What I like about this idea of it being a cycle is that it doesn't end. It's bi-directional. Sometimes you move forward and then you have to move backward around it. It's dynamic. Each phase influences each, other phases as well. And that's a huge asset of it. Like with intent, it looks like that. So, the first part, identifying the problem, identifying the gap, and, figuring out sort of how do we create some tools to identify and address that. Great. Adapt at the local knowledge to the local context. So this is where you create your intervention and then you might test it at your site, wherever you're embedded, whether that's in a community practice, whether that's in an academic medical center, make it work for you and see what that looks like. And then think about and assess what were the barriers and the facilitators to the knowledge use. And this can go, this requires working very closely with stakeholders, with patients in partnership, with parents in partnership, community providers. It takes time to really think about this phase of it. And hopefully, if you've done this part right, if you've invested and made these partnerships, what you come out with is something that's even stronger and better for it. So tailoring the intervention, very important. Monitoring the knowledge use. So then as you're thinking about sharing it and disseminating it in this phase, really staying very close in touch, not just putting it out into the world and leaving it, but continuing to engage with your knowledge users, with the people that are the boots on the ground that are doing the intervention, looking at the outcomes, sustaining the knowledge use, and then sort of back at it again. This is the work that we've been doing with the comfortability. And, when we think about, again, I'm talking psychology, but think big picture for wherever you are, what psychological intervention treats chronic pain and for whom? We're really keen on understanding that as a central focus. And it's very, very important to understand things under controlled conditions, but it's got a lot of caveats. Just that it works in a controlled environment says not much about the generalizability. And that systems level real world application is a big piece of the puzzle that we're all trying to solve. So I think the other questions we want to just have on play in our mind is, what works within our healthcare system? How will consumers access this? How does this intervention improve health equity? How can this be systematically implemented? Who are the adopters? Who pays for this? How flexible can this be while still maintaining fidelity? And how is this sustained? So this is really such a big piece of this. One of the things that I came to understand about myself through my career is that I am a pretty impatient person. I love the idea of controlled research, but actually am more energized by actionable change that sort of boots on the ground, get it up, get it out, and do it in a responsible, effective kind of way. It's messy, it can get really complicated, but it's also incredibly rewarding to be able to see the change as it's occurring. So I want to talk, let me just check for 1 second on our time here. Oh, good. Okay, so let me, I guess I would say these questions are a big part of what drove the initial creation and where we are now with the dissemination of the Comfortability program. So I'm just going to give you a really quick overview of what the program is for those that might not be familiar. And then I'm going to talk a little bit about what our network looks like and how that has really been such a fundamental piece of how we generate new knowledge and new assets and continue to disseminate this work. Okay, so the Comfortability program, we're all about teaching kids and parents proven skills to manage chronic or persistent pain. And the program, I originally developed it in 2011. So we are in our 12th year, which I always remember because I launched it when just before I gave birth to my second son. So that his birthday and the birth of the Comfortability were very much aligned. So 12 years, it's a long time it's been running, but we've, much of that first phase, that sort of testing and developing the content, testing at the local level, that was a big part of the first phase of it. And as we have grown, we are now a team. So just before I go on to talk about the work, I would like to say that while I spearheaded, this is now very much a team effort. This is my CAP leadership team. Right now, Dr. Bujaranu and Dr. Rachael are integral members of our team. And then beyond our leadership team, we also have an amazing program manager, a biomedical informatician, medical consultant, and clinical research specialist. And I want to give a shout out to our incredible peer advisory board and parent advisory board, who many of whom have been with us for several years, who are integrally tied to the work that we're doing at every step along that knowledge to action cycle. They're boots on the ground providing peer support to our patients. They also review materials for us. They also come up with new ideas. Incredible. They're incredible to work with. Also, a lot of support from our department and our organizational partnerships and network, who I'll talk about in a minute. So a big thank you to everybody for this body of work. Okay, so its Comfortability program, or CAP, as I'll just call it from here on out, is a first line intervention. It's really designed, we talked at sort of those basic assumptions at the beginning. Our mission is to teach kids and parents the evidence-based tools that come from psychology. And we want to do it in a way that deeply engages them, educates them, supports, and empowers them. That is really critical, because if you're designing a first-line intervention, we want to pull them in. We want them to know why and how psychology can be helpful. For some patients, this might be their only touch point in their clinical care pathway. And for others, this is their first touch point on that clinical care pathway. They might need individual care. Maybe they need a rehab program, but this is setting the foundation for that. So really giving them some first line skills and engaging with them, like partnering with our patients in this important work that we're doing. And our vision, sort of the ultimate goal here, is reduce disability and comorbidity by enhancing access to care, so making this widely available. It's a group-based treatment, so we can get lots of kids through our wait list that are waiting for service. We can treat lots of kids at once. Improved parent and child self-efficacy, which is really what our research has bared out as well, that even after this brief intervention, parents and kids have improved self-efficacy and reduced catastrophizing and some other nice things too. And connection to science-backed resources. So this isn't their last stop. We're really wanting to make sure that we pull people in and make sure that they've got access and are directed in the right way to get the resources they need. Right now, our workshops, we've got 3 workshops that have been disseminated. One is a one-day workshop. This was sort of our original format. We bring kids and parents together for a whole day We often do it on a weekend to increase access to care. And kids are in one group, parents are in one group, 6 hours of intervention for each of them. And we send them on their way after having created sort of some individual plans for each of them to sort of meet their own personal goals in pain management. So that was our first one. And then our virtual CAP program came about in 2020, really quite aligned with the pandemic. That was definitely the impetus for it. But now that has been also disseminated as well. I'll talk about that for a minute. And then our CAP for sickle cell pain program, which was a disease-specific modification that we did using some intervention mapping techniques. And that one also has been disseminated. In addition to our workshops, though, we have some other really essential assets that are part of this body of work. One is a professional training portal that we use to onboard or up-train new sites. So if we've got modified materials, if we've got new flyers, if we've got a new aspect, because the program is iterative, we're continuing to develop as we go. There's a place for people to go and do that. I mentioned our advisory boards, which are top-notch, they're amazing. And then ongoing patient support. So we offer online health chats, boost our content through our website, and then opportunities for collaborative research with our partner sites. Each of our workshops has 4 basic principles. They get a big dose of psychoeducation, really understanding what is CBT, why do you need to know about it, how does it help with pain. They get pain neuroscience education, hands-on skills training, because you can't just tell kids what you want them to do. You have to partner with them and actually do the things. So very, very hands-on and social support. I won't read through this, but just take a look through. I'm putting this up here just to say, think again about that funnel, that knowledge synthesis we were talking about in the center of the knowledge to action cycle. CAP is designed to really align with our strongest evidence base in psychology. Again, that's dynamic, it shifts, but what do we know now? And includes the evidence-based psychotherapeutic approaches that get us the biggest bang for the buck. And then again, another key factor in our workshops is that engagement is key. So we use multi-method learning, written workbooks, didactic instruction, peer mentorship, interactive videos, in vivo skills practice. So again, we're really trying to pull people in so that their first experience with psychology is really positive, and that it has meaning and impact for them. So let me talk for just a second about our network. This is a snapshot of sort of where we are. I couldn't fit Australia on the big map, so shout out to my Australia partners who get a little love in the right-hand corner there. Right now, we have 27 partnerships with hospitals through the United States, Canada, and Australia. We've trained over 200 providers and treated over 5,000 patients and parents through this intervention. What I'm really proud of is sort of how we've grown by year. So I said that we started in 2011. The first time we disseminated or shared with the site was in 2014. It was sort of a beta test site. Could we pack it up? Could we ship it off? Could we train people to replicate? And we had a great partnership there. Recently, that site became inactive due to insufficient resources there. But based on what we learned through that partnership in 2015 is when we really started to disseminate in earnest. And that's been an ongoing process through the pandemic, through the past, 7 years. We have 27 committed sites. The ones that are in yellow that you see here are licensed and somewhere in their training trajectory. They haven't launched yet, but we've not, other than our first beta test site, we haven't lost anybody. So we've got 95% maintenance through our growth over 7 years, which is just fantastic. That makes me so happy because it's one thing to put it out there. It's another thing to keep it going. Building this network, has been a labor of love. It is because we designed this when we were ready to launch from the ground up, we thought about how do we disseminate? We thought about all of those principles of that implementation science framework. And the systematic professional training and transfer. These have become, I think about CAP now as having two arms. There's sort of our clinical arm, what we're developing, the actual content of the intervention. And there's this other massive, equally important arm, which is how do we do our training and transfer? What does that look like? And then how do we hold our sites through our CAP network so that we can create this iterative knowledge mobilization process? That's the action cycle all the way around the outside border of that knowledge to action cycle. And we have a lot of different ways that we do this. One mechanism is our CAP consultation forum, which is a monthly group that we run for anybody that's in our CAP network. Any of our sites, could be administrators at a site could join for a consultation forum meeting, could be clinicians, site directors, trainees, but it's an opportunity. These are sort of what you see here are some of the topics that we've had over the last few months, but it creates a collaborative discussion. It supports our providers who really are the boots on the ground, spurs clinical innovation. People are like, I was wondering about XYZ, and we say, that's really cool. Let's put that on the docket. Let's study that. Let's collaborate. Let's think about how we get that into practice, and increases engagement and really supports the sustainability. In addition to that, we have network emails that go out. We've got newsletters. We do direct outreach at least once a year with our sites where we just say, hey, let's check in and see how things are going. Every 3 years, sites have a fidelity check. So we can just check in and see how things are going to make sure that the intervention is running as it should. And then we do yearly surveys, really getting a sense qualitatively of how things are going. What's going great? What's been hard to sustain or what's been challenging? Because always there are challengings. Also, we just had a pandemic or in the pandemic, all of that has really influenced and changed what we're doing. If you're not nimble and if you're not connected, things are really going to fall flat. So I'll just walk you through really quickly what this looked like, how this network really informed. I know this is busy, so stay with me for 1 second, but how our network really helped to inform some of the work that we did in creating CAPV, or our virtual telehealth program. When the pandemic hit in 2020, all of our partners, I can't remember, I think we maybe had 17 or 18 at the time, everything came to a screeching halt. You could not run a group in-person workshop. Wasn't going to happen. So in March of 2020 was the last time that at Boston Children's we ran our in-person group. It was literally like the weekend before everything shut down. As soon as that happened, we sort of sprang to action. We used what's called intervention mapping, which is a planning framework that really provides a systematic process and protocol for sort of a step-by-step decision-making for intervention development, implementation, evaluation. So we looked at what was in the workshop. We looked at our research. And we said, what's working really well? What do we want to distill down? What's going to be really hard to deliver virtually? And what can we do to close that gap? In April of 2020, we already piloted our first virtual intervention. And then in May of 2020, we partnered with Stanford, who said, punt it to us, let's try it in our system. It's one thing if it works at Boston Children's, but we need to know, does it work in another system too? So they piloted it. We get feedback from them. We revise iteratively, like what have we learned? We reshape, run it a second time in May at Boston Children's. We punted it to Alberta, one of our partner sites, who in June 2020 ran it in their system. How did that look? What did we learn from that experience? We took that data back, we revamped again, and then by July of 2020, we were ready to build some of the systems materials that support the implementation. And then in October of 2020, we started to do group trainings. We tested it a few more times, make sure we worked out a lot of the kinks. Was it perfect? Definitely not. Did people need access to something immediately that was nimble and could work? And we could say, we didn't know about efficacy at that time. what we knew is that we've tried this in a couple systems. We built it carefully from the intervention that was working really well, and you're welcome to implement if you want. And we, started to share what we had so that people could be working from something. Now we're engaged. In 2021, we started a multi-site study where we're looking more systematically. We've got 5 sites looking at patient experience, looking at provider experience. All of that matters. But it just gives you a sense of when we're working within a system like this, the opportunities that can really come from building a network to support this. This is just a shout out and a snapshot to all of our partner sites, some of which have been with us for many years. And when I say that we could not do this without them, I mean, we learned so much from our partner sites, and grateful that at the hub at Boston Children's, we're able to synthesize a lot of that. Our sickle cell program, after we started disseminating that, went through a complete revision. We changed language, we changed formatting, and now we're sort of revamping that. And our full workshop has gone through 1 revision. It's on its 2nd revision now, and hopefully will be out soon. But all of that came from learning about these different systems level pieces of the puzzle that are so important for the generalizability. I want to just, it's a big body of work. And like I said at the beginning, thinking from this implementation science framework can feel overwhelming. It can feel messy. And I just want to share a few words of encouragement because I think the more people that we have doing this work, and there are some amazing people that are already, doing this work very, very effectively. So I certainly am not alone in doing this, but I think I want more of it. The more I see of it, the more I want it. So just keep in mind that you don't need major grant funding to get started. If you happen to work within an ecosystem like an academic medical center, think about the resources that you have in your back pocket. I'll just give you an example of that. Like when we were building our provider portal, it's a big undertaking to create a portal that has access to all of these materials. It's got training videos, it's got grant materials, it's got administrative materials, and everything you need, right? So it seemed like a big expense. It seemed like it was a big project, but then I came to find out that there was a team within our hospital system that could help us with that and with the delivery and development of that, which was a major coup. So I think, just think, ask around, see what's been done, and then think from the systems perspective from the ground up, working collaboratively, like being out in the conference world again is completely amazing and opens up a lot of really important discussions, but stay open to new ideas. And then I think a really important part of it is sticking with it, which doesn't sound glamorous, but like this, as I said, we've been at this dissemination phase anyway for 7 years, and it's iterative. But you can't just, the idea of developing something, proving that it works, and then letting it sit just feels like we're not going to get where we need to get. So I just encourage you to sort of figure out what it is and keep on keeping on. So a few take-home thoughts or messages, and then we'll have a few minutes for discussion and questions as well. So, thinking about this, thinking from the network perspective, sustaining resources to refine and enhance pain interventions over time is a challenge. When you build a systemic network of providers and collaborators, it helps. And ChildKind is an amazing example of this. The work that they're doing in certification, yes, it's great to be able to display the stamp of approval that it's a ChildKind site, but much more than that. What it's really doing is creating a network of sites who are sharing policies and procedures and interventions, and information about what's working well and what's not working well. And, for that stamp to stay current and valid, it's not just a moment in time, it's really about the ethos of what it is that we're doing. So think about sort of using that framework. The multi-sectoral relationships takes time, but it's essential. The stakeholder collaboration, working in partnership with patients, with parents, with providers, with community activists, all of that is essential. And then I think, I want to encourage everybody, I think one of the things I would say that has surprised me most about my work is just how much flexibility is needed, and staying open to dynamic adaptations. And I'll give you a quick example of that. Just a couple of weeks ago, one of our providers who's running the virtual comfortability intervention contacted us and said, hey, we've lost some resources here. So I'm the only psychologist on deck, and I've got all of these other asks on me right now. I'd like to continue to deliver this, but to do so, I really need to space out the intervention, the sessions, more than is part of the protocol. And is that kosher? Can I do it? And while it would be real easy to say, no, we don't have data on that, I can't, if you're going to administer it, you have to do it within fidelity. But that's actually not what we're about. Like, this is an opportunity. Nobody's run it that way before. Would you partner with us in evaluating how does this work for patients? What do you think about it from the provider perspective? How does that fit into your system? Because maybe that opens the door for another application of it or a different delivery system that we hadn't considered before. So just to be thinking about it, and with the full caveat that, like, you can try it. I don't know. I can't promise that you'll have the same outcomes, but if you want to do it, it might be worth doing it from this mindset of let's understand what this might look like. So, and then lastly, that treatment is only effective if it can be delivered. Obviously, that seems like common sense, but I think the training and the transfer are really essential to equitable and sustainable access. So thinking about how does this move, how does it travel from one place to the other is a really important part of this intervention work. Okay, and with that, I will say thank you. And if anyone has questions, please feel free to reach out. I really love to hear from people and collaborators. Email me. I'm on Twitter. You can find me there too. Or any questions about the comfortability program, you can see the information about the program there. And then I'm not sure if we share slide decks or not, but I'm happy to make my slide deck available. And at the tail end of here, I've included some extra resources around chronic pain treatment, because why not? Let's share and deliver and transfer as much as possible. So I've got some website resources and book resources and references at the end as well for people. I'll stop there.
Thank you, Rachel. That was great, not surprisingly. I'm going to ask everybody to turn their cameras on if they have one, because we like to see your faces, because we're going to have a little time for questions. But as the master of ceremonies, I get to take the first question, and then if people don't ask questions, I will call on you. So I have kind of two questions, Rachel, related, and they're not necessarily specific to comfortability, but any kind of virtual intervention, I guess. So number one, incorporation of virtual intervention, specifically psychological interventions, into EHR. Because that seems to be a way to do implementation and get it out to more people. And then the second question is, access to chronic pain programs for kids is really challenging. And is there a way to move comfortability or any virtual intervention upstream, beyond the App Store, but to really help people access it, know that it exists, and study if it works in those environments? So those are my two somewhat related questions.
So I think, yes, great questions. The upstream one, I love it. I absolutely, like, we think about, this is really like a tertiary prevention program, but I'd really love to get into primary prevention. Like, we know a lot about acute to chronic transfer and who's vulnerable and at risk. And that probably looks a little bit different from what we've done right now in comfortability, but I have so many ideas percolating. I would love to get a version of this, or a, whether it's delivered virtually or, what that might look like, I don't know, but yes, into primary care. So we can help kids get to this sooner, with the idea that right then maybe they peel off, maybe they don't become part of our massive statistics on who has chronic pain. So I think that's a brilliant idea. And then the access part. Sorry, the first part of your question, Bill, was
use in EHRs, and how how you might make that happen.
What EHR?
Electronic health record.
Oh, into the health record itself. Sorry, we call them EMR. But the well, I don't know. So what are you?
So I'm wondering,
yeah.
so if a physician, for instance, could order a digital psychological intervention, and then they could track how their patients used it, that would add an additional layer, I think, of easier implementation, maybe, and tracking, et cetera. So
that's what I see what you're saying. So the virtual intervention that we run is clinician led or provider led through telehealth sessions. I absolutely think there's a place for things that can be completely digital, but I think as a first line, I think we have to be really careful in thinking about that, because as soon as I step into my parents' shoes and I think about, would I do a digital intervention online, independent of, being able to sort of really connect with somebody around this? I don't know. I worry about the sort of uptake of that, although I agree being able to monitor it would be useful. And maybe there's some sort of hybrid, like they work with a trusted provider. It's one of the reasons I think comfortability has been so successful, is because that point of contact is with somebody that they've already, they're already in a medical system right now, in a healthcare system, and they feel held by that system. So we're not outsourcing to, an app or something completely different. This is sort of within. Again, there's lots of room for innovation. Like, this isn't the only way to do it. So I think that would be great. I think that is coming down the pipeline also. I will say that we have a grant right now. We're developing a chatbot that's going to be connected to the comfortability program, that's going to really help guide parents in creating, and kids in creating, their sort of what we call a scaffolding plan, or the stepwise plan for shifting behaviors and improving function. So something like that, I think, could absolutely, down the road be implemented as sort of an offshoot of this.
Great. I think we have time.
Yeah, thank you.
Now that I've sucked up all the time, we have time for one more question. Anyone?
Rachel, I have a question. So is there a mechanism in place for individuals who live far away from an institution that might be a comfortability institution? Is there sort of something that's not moored to an institution, if you will, so that other people could benefit from it? It would obviously have to be virtual, but at least it would broaden the access for people who live in remote areas, or areas that don't actually have a comfortability program nearby.
Yeah, right now there isn't anything that stands alone. I think when we think about our rural populations, a lot of our sites have adopted the virtual comfortability so that they can really reach, through their province or through their state, broader, people that can't come to the site. But there isn't anything, and it gets a little tricky because this isn't just education, it really is intervention. And as a psychologist, there's really, there are some careful barriers. As soon as you start exchanging information back and forth, you're practicing. And if you're practicing, you've got licensing constraints. So, and if it's completely virtual and there's no provider that's doing any of the practicing, then then I worry about the stick-to-itiveness in the same kind of way. So again, it's really, there's an art and a science to so much of what we're doing in this field. And some people might do really well with an independent kind of intervention like that, but right now the comfortability is moored to each institution.
Great. So we're going to wrap up there. But I encourage you, anybody who is not a child from a ChildKind member hospital, it is easy to get information about this. You can go to our website. You can reach out to Meredith, whose contact information is on our website, ChildKind International. We'd be happy to speak to you about that. And then we'd love to have you join us. But thank you very much, Rachel. Thanks, everybody. And enjoy the rest of your week. Take care. Bye-bye.
Thank you.